Hello friends, now I will be talking to you about a very important topic, that is coronary artery disease. It is a atherosclerotic heart disease. That means the main pathology of the problem is atherosclerosis of the coronary artery. Now let's take a case. In your outpatient department, you get a patient, Mr. A. He is just 42 years of age. He is diabetic for last 10 years. He is hypertensive for last 10 years. He smokes about one packet of cigarette for last 10 years. Smokes maybe for 10 years, and recently he got his lipid profile and his LDL is raised. This is the patient. He come to you, he says, doctor, when I walk, I have pain chest. And now when I stop, the pain disappear. Rest, pain disappear. This is the patient. Mr. A comes to us. Let us proceed. What is the diagnosis, how to proceed, how to investigate, and how to treat. Now, if you talk about clinical diagnosis, it seemed to be a case of angina pectoris. Angina is best diagnosed by history. Diagnosis is by history. Is the best way to diagnose angina. What is the classical history? The patient has classical triad of symptom. First of all, patient has retrosternal pain chest. Pain chest. This is first. Second of the aspect of the triad of angina, pain increases on exertion, and pain is relieved by rest. This is the classical triad of angina. That's why angina is best diagnosed by history. ECG may be normal, cardiac enzymes are usually normal in the case of angina. So, this is in this case also the typical history of pain increase on walking and reduce or disappear on rest is the classical history of angina. Now, what is the pattern? What is the characteristic of the pain chest? Pain chest in a case of angina, it is squeezing, dull, squeezing, heaviness in chest, in the retrosternal area, and this pain may radiate to arms, neck, back of the chest, or sometime even the abdomen also. Now, the duration of pain of angina, it is never less than 15 seconds, and it is usually not more than 15 minutes. So, at time if you get a patient who has sharp pain, remember here it is a dull pain which lasts for only few moments, or with changes which increase on change of posture or change with breathing. It is not a case of coronary artery disease, it is not an angina, right. So, here the patient come to us. So, now clinically it looks like to a case of pain, case of angina, and I have recorded a separate lecture on how to approach a case of pain chest that you can see, but at the moment we will talk only about the coronary artery disease, especially angina. Well, so now yeah. So, let us see what are the risk factors for a case of coronary artery disease. The risk factor. Risk factor are males. It is much more common in males as compared to female, especially before the menopause. But after menopause, females also have the same or maybe more than males regarding coronary artery disease. Age is increasing, age is also a risk factor. Now, after that, diabetes, hypertension, increased lipid and smoking, they are the 4 major risk factors for a case of coronary artery disease. Look at this patient, he is diabetic, hypertensive, smoking, hyperlipidemia, he has all the 4 major risk factors, right. Then there are certain minor risk factors like obesity, family history, positive family history of CAD. What do you mean by positive family history or so called premature coronary artery disease? If any close family member, male patient having CAD below 45 years of the age, or a female having CAD before 55, this is known as premature CAD, and then we call as positive premature history of coronary artery disease, a positive family history if we talk about. So, this gentleman has all the 4 major risk factors. So, when we will be treating a case of angina, these major risk factors has to be taken care in the planning. Now, increased homocysteine is another minor risk factor for a case of coronary artery disease. So, well, patient has come to us, now we plan to investigate the case. On how to investigate? Best initial test is ECG. It is the best initial test. In a case of angina, ECG may be normal, or you may get ST segment depression. Look at this ST segment depression. Now, what is the criteria of ST segment depression? The ST segment is sloped down of 1 millimeter for at least 0.008 second. If it is for minimum 0.8 second and it is at least 1 millimeter downflow, then it is called as positive. This thing ST segment is depressed. But at time you may get ST segment elevation, ST elevation, and this ECG finding is classically seen in Prince metal angina. Prince metal angina. Prince. So a few words about Prince metal angina before I proceed further. This entity, Prince metal angina, it is usually seen in young females. Young female. They have pain chest at rest, maximum in the morning time, and in these cases the ECG will have ST segment elevation like this, although this finding is more typically seen in acute MI, which I will talk later on, but this finding is there. And in these patients, in addition to the usual treatment of angina, we also add diltiazem. Why diltiazem? Because the main reason of this Prince metal angina is coronary vasospasm. Vasospasm. So it is a coronary vasospasm which lead to obstruction to blood flow. So we give diltiazem, which are a very good and very potent coronary vasodilator. Plus we also give nitrate in this patient. In Prince metal angina patient, normally we avoid beta blockers. Beta blocker are to avoid it because as such beta blocker they tend to lead some amount of vasospasm, so beta blocker are usually avoided in this patient, and we prefer to give diltiazem. So this was a brief about Prince metal angina also. So suppose ECG is normal, there is no abnormality, ECG is normal, but patient has strongly positive history pointing about the angina, then what to do? Then we advise the patient to go for treadmill test, TMT. Now, before I discuss the TMT, let us learn so in the basic fundas, well, in angina the pain increase on exertion, relieve on rest. So what is the pathogenesis? This is the coronary artery, and here is the myocardium. Heart rate is 70 and plaque is there. Okay, remember it is a atherosclerotic heart disease. Blood is coming, demand and supply are at match. Now, when the patient walks, his heart rate increases. Maybe it has gone to 126, okay, or 126. He is walking. Now, as the heart rate increases, the demand increases. Increase oxygen demand. The basic physiology that when heart rate increases, oxygen demand always increases. But supply cannot increase because the fixed obstruction is there. So it leads to tissue ischemia, myocardial ischemia. So immediately patient will have retrosternal pain chest. He stops walking. Now heart rate will automatically come back to 70. Now the demand and supply are equal, the pain is relieved. Pain is relieved. So now we understood why he had pain chest on exertion. Okay. Now this gentleman has come to us, in the best test what we did was ECG, normal. Now what is the basic principle of TMT? The patient come, we always take a resting ECG. Resting ECG, which we have already done, it is usually come to normal. Then we tie the leads on the chest and we ask the patient to walk on the TMT machine. So as the patient stands and walks on TMT machine, heart rate automatically increases, and that you can see in the monitor. So we are artificially increasing the heart rate. We are asking the patient to walk. Now as the machine belt is moving, the patient heart rate will increase, okay, 80, 90, or heart rate has gone to 104, and after some time, automatically after 3 minutes, the speed of the machine increases automatically and it's slightly elevated. The patient has to run faster. Patient has to run faster. Now heart rate has gone to maybe 116. After again 3 minutes, machine run even more fast and slight elevation. It means patient has to run much more fast. Now heart rate again has gone to 126. During that time, you can see some changes. Now what are the criteria of positive TMT test? Okay, so now you understood. The ultimately what we did was we asked the patient to run. We are artificially making him have tachycardia, and we know tachycardia will have some positive finding. So when do you say patient has positive TMT test? If patient develops pain chest. Number 2, ST segment depression of more than 1 millimeter, more than or equal to 1 millimeter for 0.08 second, or his systolic BP falls more than 10 millimeter of mercury, or he developed ventricular tachycardia. These are the criteria of positive TMT test. Okay. So if you happen to see the report goes like this. The test is positive or negative for inducible ischemia. They use the word inducible ischemia. Why? Because we have literally asked the patient to run, and we have induced the tachycardia, and we are forced to generate myocardial ischemia if it is there, to diagnose the history, to diagnose the case. That is why we use the term as positive, and if any one of these there, we say test is positive or test is negative. Now, for how long patient has to work? What be the criteria? We talk about target heart rate. What is target? How we calculate? Patient age 220 minus patient age. Suppose we get a patient of 40 years. So target heart rate will be 220 minus 40 is 180. This what is the target heart rate. But normally we don't ask the patient to run for target. At least the patient should run for 85% of the target heart rate. That is known as maximum heart rate. If patient can run and achieve at least 85% of the maximum heart rate, then we call it target heart rate. So if the patient, you are watching the patient doing exercise, you are watching the monitor. If you start getting the positive finding on monitor, maybe when the patient heart rate is 100, 120, 126, you say the test is positive. You need not make the patient run more if you are already getting the positive finding. But suppose patient running, he has gone to, remember if we talk about 180, his 85% heart rate should be around, it should be somewhere around 170. 170 is the target heart rate, and he has run and he has achieved 170 heart rate, but still you are not getting any finding on the monitor. Then you stop the exercise and then you write a report, test is negative for inducible ischemia. So let me summarize what about TMT I am talked about. First of all, the basic principle of TMT is to induce tachycardia, and number two, we want the patient to achieve at least target heart rate, which is nothing but 85% of the maximum heart rate, which we calculate as 220 minus patient age. And the positive criteria, patient develop pain, chest or ST segment depression, systolic BP fall, or development of ventricular tachycardia. Now what are the conditions where we can get false positive? False positive, that means patient doesn't have any coronary artery disease. False positive. False positive. False positive is seen in around 15% cases. This is, suppose patient already has left bundle branch block. Patient has LVH. Patient has pacemaker. Or patient on digoxin therapy. They will give you false positive test. Even false negative is in around 15% cases. That means patient has coronary artery disease, but your patient has done the TMT, the test is negative, although history is strongly saying toward the patient has pain chest on exertion, but TMT is coming negative. Then what is the further management if TMT is negative? Then we, after that we go for is stress echo. So after TMT, next best test is stress echo. What do you mean by stress echo? Here patient come to the lab, you do the resting ECG and you do the echocardiography, and you see the wall motion. Then patient go for TMT test the way we have done it. Again we are artificially inducing tachycardia, and immediately after TMT patient has achieved target heart rate, TMT is normal, Soon after this, we do the echo again. In the echo, you look for regional wall motion abnormality. We write as regional wall motion abnormality. Now let me explain to you. What do you mean by regional? Look at this thing. This is the myocardium beating, normal. Okay, left ventricle, right ventricle beating. Now this was now before the exercise. After exercise, now what you see? What you are finding? That left ventricle wall is not moving, or it is moving less. So we call as hypokinesia or dyskinesia or akinesia. This is the regional wall motion abnormality that strongly points toward the coronary artery disease. So what we see is akinesia. Akinesia means there is no movement in the a portion of the myocardium, especially ventricle wall, or hypokinesia. The movement is less than the expected. You can see, you can visualize kinesia. So we call as stress echo is positive, right? This can pick up around 97% cases. Well, suppose the patient come to you and you want to do him TMT and he says, I cannot run. This patient has normal ECG, patient says patient cannot run because of obesity, because of osteoarthrosis, maybe stroke, any reason he is not able to do exercise. Then what do? What's the alternative? We do dobutamine test. Dobutamine test. We infuse dobutamine and it induces tachycardia. So that means dobutamine test is same as TMT, exactly same, but the only difference is here tachycardia is done being by the drug, here patient is doing exercise himself. But again a tachycardia will happen if positive is there, any ischemia we can pick up. So in short, in summary, I can say dobutamine test is same as TMT test. Now same thing, dobutamine test is negative, then what the next? Dobutamine stress echo. Dobutamine stress echo. So in other words, dobutamine stress echo is same as traditional stress echo. It's clear to you? Same. It has got same. This is same as same sensitivity is there. Now what about these patients? What about these patients where TMT has no role to play? These are the patients where we do thallium or nuclear medicine study. Nuclear medicine. What we do? We do thallium or maybe test. We give patient radioactive, they are all radioactive compounds. We give radioactive thallium or radiomedical maybe, they are given. Now what the basic principle of these? We first learn the basic principle of using this. So this is the left ventricle wall and this part is ischemic. Okay. So when we give this drug, these are taken up by the normal myocardium. they are taken by the normal myocardial cell. So this area is the ischemic area, so it will be taken up by everywhere except this, so we will get a cold spot. Cold spot. So by this we can see patient has ischemia. In general, these two compound for the myocardial, this myocardium is just like potassium. It is taken up by the sodium potassium ATPase. Sodium potassium ATPase. Potassium is taken up. These compounds are exactly taken up by the same sodium potassium ATPase. Same. That means for the normal myocardial cell, they are same as potassium. If the tissue is ischemic or dead, there is no sodium potassium ATPase, they will not be taken up and we get cold spot. So in all these cases, we can very well use this test, and we can use this simple or we can use with stress. That means we can also do thallium test. Thallium stress. Thallium stress. That means you give thallium and you also go for stress. Then of course sensitivity is increased and sensitivity is same as 97%. So now you are clear about it that stress echo and thallium stress, they have almost 97% of the sensitivity. Same. But SESTA maybe is more useful in those patients who are very obese and the ladies with a large breast. Why? Because this compound has greater tissue penetrability. So they are specifically indication in very obese or ladies, right? So now we are clear about. So remember, these tests have sensitivity of about 97%. Well, now what are the next tests? How you are going to investigate further? If these tests are positive, then you go for coronary angiography. Coronary angiography, in short they write as CAG. What is the basic principle and how it is done? We can go via radial artery route or we can go via femoral artery route. So let's take about femoral artery. So what they do, it is done in cath lab. They give local anesthesia in the inguinal area and they put a needle in the femoral artery. Femoral artery. And they put a wire and they push the wire and they can see in the monitor where is the wire is going. From femoral artery it goes to internal iliac artery, common iliac artery, aorta, and ultimately they follow and they come to root of aorta. Once they reach the root of aorta, then they move toward maybe one artery, right or left. There are two arteries. Remember, anatomically there are two arteries, right and left coronary artery, but for angiography point of view we consider as three arteries. One is the right coronary artery, the other is left anterior descending and the left circumflex. So we have right coronary artery, left anterior descending and the circumflex. Of course this is the left main stem. That's why we call it triple vessel, although anatomically there are two vessels. So we have reached here and now they inject the dye. How it is done? Well, now a bigger diagram. This is the aorta, this is the right coronary artery, this is the left main stem, this is the left anterior descending artery, and this is the left circumflex artery. Okay, now they inject the dye. The dye is there, they inject the dye. Suppose plaque is here, dye will go like this. So now you can see how much blockage is there. Suppose we get another artery like this, and we got another plaque here. Plaque is there. So we inject the dye. Okay. So here it is completely blocked. There is no dye can penetrate. Here some penetration can occur beyond the blockage, some, but it is not perfusing the distal part. And here blockage is there, and this, but it is going to distal part also. So now we can say it's a triple vessel disease. Now first point, when this blockage is more than 70% of the lumen, we call as critical stenosis. More than 70% blockage is critical stenosis, and for blockage we use TIMI classification of TIMI. When we do angiography, we have to do some grading system, what we call as TIMI grading system. Grade 0, complete occlusion of the blood vessel, like this, we can say this is stage 0. There is no dye which can go beyond that. Grade 1, like this, blockage is there, but little bit of dye has crossed the barrier, but it has not perfused the distal part. So dye has crossed the obstruction, but not able to perfuse the distal vascular bed. This is grade 1. Grade 2, here the dye has crossed the obstruction. It has perfused the distal bed also, but this perfusion is very slow. So here distal perfusion is slow, here distal perfusion is not there. And finally we got normal coronary artery where complete flow is there. So grade 3 is normal coronary artery. This is how we really do the grading of TIMI. So suppose you get a reading like this, so we will call this as a case of triple vessel disease, because here 100% blockage is there, here almost 95% blockage is there, in this case around 80% of the blockage is there. So we will call this as a triple vessel disease. And suppose if this is blocked, left main stem, so we call as left main stem blockage is there, right? So now you are clear about the coronary angiography also. It is essential to plan for the coronary artery bypass surgery. This we'll talk a little later on. Now we have the patient with us. Now the most accurate test to diagnose coronary artery disease is always coronary angiography. It is the most accurate test. Most accurate test is coronary angiography. Now before I proceed further, a new thing recently in recent advances have come up. This you should know. We sometimes get a patient who has classical history of angina, pain chest on exertion. You go for TMT, ECG normal, TMT normal, stress echo normal, even angiography is normal, but still patient has exertional dull ache, squeezing retrosternal pain chest. Okay. Now just to inform you, the pain I described where he has heaviness in chest, squeezing, dull ache, radiating, this is also known as Levine sign. Levine sign. Squeezing, pain, chest, retrosternal, Levine sign. So we investigated, even angiography is normal. Then why? Now the new thing has come up. This is known as microvascular angina. What is this? Microvascular angina. The new thing has come up, recent advances. Here the coronary arteries are normal, but myocardial arteriole, they go into spasm. They go into spasm, they reduce the blood flow, and patient has ischemia, pain chest, but normal. The coronary artery are normal even on angiography, and this is known as slow flow phenomena. Microvascular angina is there, right, sir? Now patient has come to us. He is a stable case, stable angina, chronic stable angina. How you are going to treat these cases? In the treatment, first is always the lifestyle treatment of case of CAD. Always lifestyle modification. You ask the patient to control blood sugar, blood pressure, reduce lipids, stop smoking, lose the body weight. Lifestyle modification. What else we advise? Aspirin. It is the best initial treatment for any case of coronary artery disease, maybe angina, maybe MI, because it starts its action within 1 hour. Within 1 hour. It's an anti-platelet drug, and it has got definitely mortality benefit also. That means it reduces mortality by 30% if you give early in the treatment. Then we give beta blockers, especially metoprolol. They reduce the heart rate, and now by now you know the importance of controlling heart rate. They also have definitely mortality benefit. For nitrate, we give for pain chest, statins to control the lipid level, and if patient has high BP, we use ACEI, or patient is in heart failure associated, we give ACI. It also has mortality benefit. So aspirin, beta blocker and ACI, they definitely have mortality benefit, and if the patient has still pain not relieved by this giving this drug, then for resistant cases we can give ranolazine. This is given for the resistant cases of angina. So this is how we are going to manage a case of chronic stable angina. In the next lecture, I will be talking to you regarding acute coronary syndrome, which include unstable angina, non-ST elevated MI, and ST elevated MI. How to diagnose, how to investigate, how to treat, that we'll do in the next lecture. Thank you very much.